You're listening to Medscape's In Discussion series on type 2 diabetes, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Silvio Inzucchi, professor of medicine, the Yale School of Medicine, where he serves as clinical chief of endocrinology and medical director of the Yale Diabetes Center at Yale New Haven Hospital, New Haven, Connecticut. Relevant disclosures can be found with the episode show notes on medscape.com. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for you as healthcare professionals.
Welcome to Medscape in Discussion. I'm Dr. Silvio Inzucchi, and today we're talking about type 2 diabetes and our move away from glucose centricity, trying to harness the revolutionary renal effects of newer anti-diabetic agents. I can't think of anyone more qualified to talk about this than my colleague, Dr. David Cherney. David is professor of medicine at the University of Toronto in Canada, and he also serves as a nephrologist and clinician scientist at the University Health Network and Toronto General Hospital Research Institute. Dr. Cherney's research program focuses on the physiological factors that initiate kidney disease in patients with diabetes. Welcome, David.
Thanks so much, Silvio. It's great to be here with you today.
Before we get to our main discussion, can you tell us a little bit about how you became interested in studying the crossroads between diabetes and kidney disease?
Absolutely. So I did my PhD in this area and studied the effect of glucose and the effect of, at the time, medications that affect the renin-angiotensin system and other factors that are important for controlling kidney function, and got interested eventually in SGLT2 inhibitors and other therapies that impact on how the kidney regulates itself, and subsequently in trials that have emerged in this field that have fortunately shown very significant benefits for our patients in the setting of diabetes, and now in people even without diabetes. So I went from the factors that initiate disease to the trials where these therapies were used and have fortunately shown benefits.
That's one of the really interesting aspects of this field, particularly the SGLT2 inhibitors, is how we've grown from thinking of these medications as diabetes drugs, and now they're certainly used in patients, first with heart failure and now in patients with CKD.
Yeah, I agree. That's also been one of the challenges, because we've had to change our way of thinking from a glucocentric way of approaching them to thinking about their salt handling and other mechanisms that I'm sure we'll discuss afterwards that are probably much more important for how they protect our patients.
So let's start off by discussing the latest KDIGO guidelines. These are refreshed every couple of years. I think the last version came out in 2020. Will you review for us the major changes in the latest KDIGO guidelines, specifically regarding the prevention of kidney disease in patients with diabetes?
Yeah, absolutely. So the latest KDIGO guidelines have really been really important in many different respects, and they've outlined how to use newer therapies in this area too. Some of the key messages and the key factors are, first of all, thinking about how to layer therapies on top of one another. So in thinking about broad approaches, there's the nice pyramid figure that the guidelines have for blood pressure control and glycemic control, lifestyle modification, all the things that we recommend for all of our patients. And then layered on top of that, in a smaller group of patients beyond those lifestyle changes, are trying to use RAS inhibitors, SGLT2 inhibitor therapies more effectively, and some other medications as well that are used in subgroups of patients for reducing cardiovascular risk. So that approach, I think, is very helpful because it shows that there are layers of therapies that we should add on top of one another. I think one of the other important aspects of the guideline is thinking about GFR cutoffs and where we should be using newer therapies. For example, how to layer an SGLT2 inhibitor and metformin as a first-line agent on top of standard of care in patients who are eligible for these therapies, thinking about how to initiate them at what GFR thresholds, the important message around continuing SGLT2 inhibitors down to the level of dialysis or GFR of 15, and then also touching on some of the future directions around, for example, GLP-1 receptor agonists as next line therapy to reduce kidney risk. So I think the guideline really did a nice job at thinking about broad therapies and then honing down into those newer emerging therapies that are now part of standard of care, because these guidelines are now almost 2 years old, but honing down into new standards of care that can be used to further reduce risk.
So I really like the so-called heat map that I believe first appeared in those guidelines. We as endocrinologists, as primary care physicians, used to think about CKD in the classic 5 stages, 1 through 5, but now we're asked to think about how important the albuminuria cutoffs are as well.
Absolutely. So the albuminuria cutoffs are absolutely critical, and the albuminuria is sort of a gate that we should be using based on available data to know where we should target newer therapies. So we of course measure albuminuria in people with type 2 diabetes on a yearly basis. And that used to be just in some ways part of good clinical care, but didn't necessarily change practice and what we prescribe for our patients. But now we know that in patients with higher levels of albuminuria, that there is clearly a rationale for giving, for example, SGLT2 inhibitors, now for giving finerenone in people with diabetic kidney disease. So not only is it part of good clinical care to measure GFR and albuminuria on a yearly basis, it also really translates into changes in practice, which we didn't necessarily used to act on over the last couple of decades, where we had nothing beyond an ACE or ARB. Now we have those new therapies that can be added on to an ACE or ARB in people who are eligible for these therapies.
So we started our discussion about the SGLT2 inhibitors, and they've clearly garnered lots of attention over the past few years. I know you've studied these drugs for many years, and they clearly reduce the progression of CKD and are now widely endorsed for this specific role by diabetes professional societies, as well as by nephrology professional societies as well. So clearly, if our patients have CKD as denoted by a reduced GFR, as long as there is substantial GFR left, so the drugs still work, these are considered almost first-line therapies. But what about the majority of patients that we see that still have normal renal function and just some albuminuria? Should they be used in that setting?
Yeah, so that's certainly a little bit more of a controversial area right now, and it's controversial because the studies that have been completed to date, including Credence and DAPA-CKD, which were the dedicated kidney trials, included patients with a degree of kidney function impairment and also with albuminuria, more than 200 milligrams per gram in DAPA-CKD and more than 300 milligrams per gram in Credence. And so strictly speaking, in terms of the renal dedicated trials, it's those patients who demonstrated the protection with SGLT2 inhibitors. But it's important also to realize that in the cardiovascular safety trials that have been published to date, and there are many of them, that there were also benefits from a kidney perspective shown across those different trials. And those benefits extended to people with a range of GFR, including patients with relatively good kidney function, and also extended to patients with normo, micro, or macro albuminuria. So although the renal trials have not yet studied and included those patients in terms of the trials that are complete, there are secondary analyses from these cardiovascular trials that have also shown benefits in people with just microalbuminuria. So I think in terms of practice, we have to recognize that there may be benefits in those patients without macroalbuminuria, with lower levels of albuminuria, and then ultimately committing a patient to one of these therapies in the absence of macroalbuminuria needs to be a conversation at an individual patient level to weigh the risks and benefits and to decide what to do, and also to take into account their cardiovascular risk because of the substantial benefits with the SGLT2 inhibitors around reducing cardiovascular risk in patients with and without established cardiovascular disease, and also the benefits around heart failure, which are also seen in patients with and without heart failure at baseline. So all those risks and benefits need to be taken into account.
So I find this a fascinating area. Let me just pick your brain on this point. Do you think that microalbuminuria reduction is the way these medications are working? In other words, is that a marker of the effectiveness of the medication?
Yeah, so that's an age-old and very important question, because albuminuria is a very good surrogate marker of both risk at baseline. So patients with high levels of albuminuria are at high risk of future renal and cardiovascular disease down the road. And in addition to that, we know from the SGLT2 trials and with other medications that a significant reduction in UACR and albuminuria of around 25 to 30% correlates beautifully with a reduction in, quote, hard renal endpoints in terms of composite endpoints, loss of kidney function, dialysis, a transplant, or renal death. So although it is a surrogate endpoint, it's a very good surrogate endpoint, and there probably is very little else that surpasses it in terms of its predictive value, both for future risk and also as a predictor of responses to therapy.
Now, on that point, clinically, I'll pose you two questions. One is a person who has relatively preserved renal function and just some albuminuria. Would you advise rechecking the urine albumin to creatinine ratio after initiation of medication? Is that of interest to you? Not certainly from a research standpoint, but clinically, is that of any benefit in rechecking that after initiation of SGLT2s?
Yeah, it's a really important point too. So the changes after initiation of therapy are interesting, and it's important to check on a regular basis still, because patients who have albuminuria tend to still have it down the road. But importantly, it doesn't really change the management in terms of the therapy that's started. So for example, if a patient is started on an SGLT2 inhibitor or on a mineralocorticoid receptor antagonist like finerenone that's been shown to have benefits in the kidney, if the patient doesn't have an albuminuria response, I would still continue them on that therapy.
Okay.
And that's a critical point, because some patients have a huge albuminuria reduction. I've seen 90+% reductions, and some patients have relatively modest benefits in terms of UACR reduction. That wouldn't make me abandon a therapy.
Okay.
So that's a point one. Point two is that if someone still has persistent albuminuria when they're on a RAS inhibitor and then on an SGLT2 inhibitor, it's important to remeasure the UACR, because that will tell you what to do next. And so if a patient still has persistent albuminuria, that might be an indication, for example, to add a GLP-1 receptor agonist after that, or to add finerenone, or perhaps some of the emerging therapies that we'll hopefully have in the future. So it's still important to think about what to layer on next. And when patients are on an SGLT2 inhibitor or on finerenone or on a GLP-1 receptor agonist, they still have residual risk. So the purpose, just like our heart failure colleagues do for heart failure, we have these pillars of therapy. The idea in the future is that we're not going to be choosing between different kidney protective therapies. We're going to think about how to use those therapies together. So kidney pillars, not heart failure pillars, and to maximally reduce residual risk as much as we can. And albuminuria helps to guide that.
So the second patient type is somebody who has reduced renal function. Let's say their GFR is 45. So same question, rechecking albumin certainly makes sense. But what about rechecking the creatinine? Has that been your practice? Because as we all know, you do get a little bit of reduction in GFR initially with these medications.
Sure. So in terms of checking, serum creatinine and GFR, certainly the first important point is to check it on a yearly basis or more frequently, depending on the level of impairment in kidney function. And then checking it after initiation, as we do with an ACE inhibitor or an ARB. So with an ACE or ARB, I definitely check the creatinine after initiation, generally about 2 to 4 weeks after starting, because one, ACE and ARBs can cause kidney injury, rarely, but they can. Especially in people with serious renal vascular disease. And two, they can cause hyperkalemia. So we want to know about those two issues if they arise, because that will change our management. We might back off on a diuretic or back off on another antihypertensive, or reduce the potassium levels with a novel binder, for example. So it would change management. In contrast, with an SGLT2 inhibitor, we know that these therapies actually reduce the risk of acute kidney injury, and they reduce it consistently by about 20 to 25%, both in real world evidence studies, so in electronic medical record database studies. And we know that is the case from clinical trials as well, including in people with impaired kidney function, like in patients with diabetic kidney disease who were enrolled in the existing studies. So we know that there's a reduction in AKI risk. And we also know, interestingly, that there is a bit of a reduction in the risk of hyperkalemia, probably because of the natriuresis and increased urine flow that gets rid of potassium. So I actually do not, that's a long-winded answer, sorry, but it's important to understand why I don't check the creatinine or the electrolytes in most patients after starting an SGLT2 inhibitor, because of those factors that are different and contrast with what we see with an ACE or ARB. I tend to just check it at the next visit, unless there's some particular concern that I have about an individual patient based on lowish blood pressure or age or frailty or other issues that are important in that specific person. But generally, I don't.
So even in a patient with a GFR hovering around 30, you wouldn't recheck after a month?
Yeah, 30 is around my cutoff. So 25 to 30, which is where we're typically the lower end of where we're using them in patients with kidney disease. 25 to 30, I typically do. Those patients also tend to have a lot of other comorbidities. They tend to be more frail and elderly. So those are the usual reasons. But if I have a robust, 35-year-old or 40-year-old with just albuminuria and a GFR of 30, then I actually would not check it. I would check it at the next visit.
Okay, that's really helpful. It's what I've been doing. Another related question: is there any drop in the initial GFR that would compel you to discontinue the medication? That always comes up.
Absolutely. So also around 25 to 30%. So when it's that degree or more, then that's concerning. And I would certainly repeat it within 3 to 5 days to see that it's typically coming back up again. What we typically see is that after the GFR dip, the GFR tends to return back to where it was. And so as long as it's returning back to where it was, I would just sit on my hands, do nothing, and then watch and wait. If the blood pressure is low in that setting, lower than I want, typically less than about 120/70, then I would think about backing off on other antihypertensives or diuretics and reversing anything that I can. But most of the time I just watch and wait. That's very rare, by the way. That reduction of 25 to 30 is extremely rare.
Yeah, most are in the 5 to 10% range.
Yeah, exactly.
So let's talk about the American Diabetes Association guidelines. These are published annually in the journal Diabetes Care. They're called the Standards of Medical Care for Patients with Diabetes. And there's an algorithm that's well publicized that tells us how to use glucose-lowering therapies sequentially, typically starting with metformin, although some of us are getting away from that as foundation therapy. And then over the past 4 or 5 years, there's been a focus on the comorbidities of our patients, whether it's ASCVD or heart failure or CKD. So let's focus on the CKD group. It used to be that if there was CKD present, again, as long as there was sufficient GFR that was preserved to allow for use of the SGLT2 inhibitors, that those would be the natural choice, because our goal, at least one of our goals here, is to prevent the progression of CKD. In the last couple of iterations of these guidelines, there was this change, a little bit of a nuance, but this notion that if the patient had CKD and albuminuria, micro or macro, then the SGLT2 inhibitors would be the obvious choice. But if there was no albuminuria, and the inference, I think, was that this was not really diabetic kidney disease or DKD, which one can argue with, that then the choice would be either a GLP-1 or an SGLT2. I'm not sure I practice that way. I think anyone with CKD, irrespective of the presence of albuminuria or not, should be on an SGLT2 inhibitor. What do you think?
Yeah, so I think it's a very important point, and I agree that is a little bit difficult to follow in the guideline. And it seems to be that the recommendation is that the CKD in that flow diagram might, in fact, reflect future cardiovascular risk and therefore equate an SGLT2 and a GLP-1, which I disagree with. So I think that from a renal perspective, we're thinking about CKD risk, not thinking so much about the cardiovascular risk. If we're thinking about the CKD risk and the benefits of these therapies, there's no question that there is a huge body of evidence in support of the SGLT2 inhibitors as medications that reduce renal risk, both in patients with albuminuria and, as mentioned before, even in analyses from the CVOTs in patients with and without impairment in GFR, with and without elevations in UACR. So there's a huge body of evidence that supports a preference for an SGLT2 over a GLP-1 from a renal perspective right now, with the caveat that there are ongoing trials with the GLP-1 RAs that will elucidate some of the mechanisms and also whether there are benefits in patients with established DKD, like the FLOW trial. But I think the preference should clearly be for an SGLT2 inhibitor. The other just important point to mention, I think, is that the most compelling data for the GLP-1 receptor agonists, based on secondary analyses from LEADER and SUSTAIN and REWIND and others, is that the best evidence supporting GLP-1 receptor agonist protection for the kidneys in patients with low GFR, so GFR between 30 and 60, who have micro or macro albuminuria. So it's those higher risk patients who appear to benefit the most with the GLP-1 RAs. There's also nice data by Kathy Tuttle from Award 7 showing the same thing. So I think the best data is in people who have kidney disease for the GLP-1 RAs. So again, I think that it's SGLT2s clearly the preferential therapy, And then GLP-1 array would be a next line, just like the KDIGO states in the flow diagram.
And the suspicion is that these drugs, although it's obviously an expensive undertaking, could have complementary benefits as far as the kidney is concerned. We don't know that for sure.
From a mechanisms perspective, complementary mechanisms of benefit with the SGLT2s, they're potentially much more or predominantly hemodynamically protective. They probably have benefits on suppressing inflammation and fibrosis and hypoxia and so on in the kidney as well. Whereas in contrast, the GLP-1 receptor agonists are likely predominantly beneficial in the kidney by non-hemodynamic mechanisms, by reducing inflammation, fibrosis, as well as the powerful metabolic effects they have on reducing weight and A1C, which may also reduce microvascular risk too. So I think there are definitely rationales for different mechanisms of benefit.
So let's talk just briefly about mechanisms. How the heck does a drug that increases glucose in the urine have such a dramatic benefit on the progression of chronic kidney disease?
So that's a very good way of phrasing it, because absolutely these therapies increase glucose in the urine, and they increase glucose in the urine in people without diabetes too, just to a much lesser extent compared to someone who has ambient hyperglycemia and diabetes. But we also know that these therapies are, in terms of their benefit in the kidney, they have their mechanism of action that is completely independent of glucose. And in fact, they are effective for reducing kidney risk, even in people who have normoglycemia and no diabetes. There's a beautiful figure that was published in Diabetes Care sometime last year, which shows the hazard ratio or the benefit across the DAPA-CKD cohort, where the hazard ratio was below 1 and significant from an A1C of 4 to 12. So it didn't matter what the A1C was. There was clearly a statistically significant benefit across the entire spectrum of A1C. It doesn't matter what the A1C is. So the benefit is likely on the basis of changes in glomerular pressure. So these medications are natriuretic, and they kind of trick the kidney into reducing pressure at the level of the glomerulus, kind of like an ACE or ARB does. And in doing so, reduces albuminuria and reduces all of the intraglomerular pressure and wall tension that causes fibrosis. That's probably the main mechanism, but there are other mechanisms that are likely important too, like the anti-inflammation and anti-fibrosis and anti-hypoxia mechanisms as well.
But also complementary to RAS blockade, correct?
Absolutely. RAS blockers probably have a similar effect on reducing glomerular pressure, but they probably act differently. They act at the outflow arteriole at the glomerulus, whereas the SGLT2s work predominantly at the inflow arteriole of the glomerulus, although that's also become a little bit more controversial recently. But that's likely the main mechanism of how they reduce pressure in the kidney, and that's why they work so well in a complementary way.
David, we're running out of time. I wanted to pick your brain once more just about RAS blockade in patients who are not hypertensive. So your typical type 2 or even a type 1 diabetic patient who has microalbuminuria but has a normal blood pressure. Are we still supposed to be using RAS blockade in those individuals?
Yeah, so to some degree, it depends in very low risk patients, so patients without albuminuria, with normal kidney function, no hypertension. So it depends a little bit about type 1 versus type 2. And clearly from my read of the previous trials, there's really no supportive data for use of an ACE or ARB in someone with type 1 diabetes who has no hypertension, no kidney disease. We have trials like the RAS trial, for example, that didn't even show any benefits on kidney biopsies in terms of primary prevention with an ACE or ARB. The story is probably pretty different in type 2 diabetes, though, because there is nice primary prevention data, albeit with a surrogate with albuminuria, showing that that ACEs and ARBs in the Benedict trial, the Roadmap trial, and others show reductions in new onset of albuminuria with an ACE or ARB as primary prevention. And then most of my patients would have gotten into the HOPE trial, which is now more than 20 years old. And the HOPE trial included people who were 55 years and older who had either established cardiovascular disease or type 2 diabetes with another risk factor. So with hypertension or with albuminuria or microalbuminuria or with hyperlipidemia, for example. And most of my patients would have gotten into those trials. So even though they don't necessarily have kidney disease, there was a very significant benefit in the HOPE trial. And so that's another potential indication for treating a patient like the one you described to reduce cardiovascular risk. And then there are those other trials suggesting renal benefits, even in patients who don't have very much clinical disease. So bottom line is there is usually a reason to treat someone with type 2 diabetes with an ACE or ARB. The obvious exception, of course, being someone who's very young, who wouldn't have gotten into any of those trials, who you're committing to a medication for many, many years, where that is certainly a more personalized discussion.
Very good. Well, Dr. David Cherney from the University of Toronto, thanks so much for sharing your thoughts today. It's been a fun discussion.
I really enjoyed it. Thanks for including me.
Thanks for listening. I'm Dr. Silvio Inzucchi for Medscape in Discussion.
Thanks for listening to Medscape's In Discussion Type 2 Diabetes podcast series with our host, Dr. Silvio Inzucchi. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com for show notes, links, and more information on type 2 diabetes.